So we always have to think about the two things, the epileptogenic zone and all the important areas of your brain that are very close to it. So we have to protect one and try to remove the other one.
Welcome back to Epilepsy Sparks Insights. Today I am thrilled to be joined again by Dr. Ricardo Morcos from UCL. If you've ever wondered why the epilepsy surgery pathway exists or what it really means, this episode is for you. Around 30% of people with an epilepsy don't respond well to anti-seizure medications. So what is next? Well, Ricardo walks us through the whole journey. How and why people are referred for advanced therapies like surgery, the stations on the pathway, clinic visits, MRIs, video telemetry, neuropsychology, MDT meetings and more, what the famous tube map is and how it helps patients and clinicians navigate the system, common fears and myths about epilepsy surgery, and other treatment options, including neuromodulation and clinical trials. Whether you're a person with an epilepsy, a family member, or a clinician, this episode will help you feel informed, empowered, and less overwhelmed by the process.
So why does the epilepsy surgery pathway exist? And what does it even mean?
We know that approximately 20 to 30% of epilepsies in general don't respond well to the anti-seizure medications, to the pills. So for all those patients, we need to find a better solution to treat epilepsy and improve seizure control and quality of life. Mm-hmm. And that I think we discussed it in our previous podcast about cenobamate. Usually after 2 anti-seizure medication, if we try it and it's the appropriate anti-seizure medication for that type of epilepsy, the chances of being seizure-free after that second or third trials are very low, like less than 5%. The only different drug was cenobamate that gives you up to 20% of seizure freedom. But in general, if we have tried all the anti-seizure, or a couple of anti-seizure medication and cenobamate, and the best option forward will be advanced therapies. And the main one is surgery. So this is why there is a complex and long pathway to assess patient and if they're suitable for surgery or any other therapy.
And I guess it's called a pathway then because you have to go through several almost what might feel like roadblocks, but no, that's not the fair term, but different clinicians that you see to check, okay, are you the right person to have this type of surgery? If not, what is the next step? And things like that.
Exactly. It's like a teamwork. It's multidisciplinary. It has multiple steps. Not every person does the same pathway, goes through the same route. Some of them are faster because not every epilepsy is the same. And so it's a very personalized pathway, although there are 4 big routes that we are going to explain.
Yeah.
We have to try to explain this in a simple way. And like the tube, the tube is something sometimes chaotic, but when you look into the map, you say, okay, you make sense of it and you know where you are and you know what is next and what are the possible options for you. So this was the idea of making a map to explain the epilepsy surgery pathway.
And it's so cool, everybody. You must check out Ricardo's tube map. It's just, honestly, it's great. Thankfully, it's simpler than the actual tube map, but it's very, very clear what you do or what you might potentially do. And it's also really good for clinicians who aren't familiar with the process. So, because that's something I think which often holds people back. The average waiting time for epilepsy surgery at least used to be about 20 years. And I mean, I think mine was 20 years before that I had to wait, and it's nuts. And a huge part of that is because many clinicians don't know about it or they're too scared to even bring it up.
The average of 20 years is from epilepsy onset to the surgery, from the date of surgery. So during that period, many things can happen. But we know that patients, many of very good candidates for surgeries are not referred or don't even know that a surgery is an option, or they consider it as the last resort, while surgery is a well-established treatment for epilepsy, and we have a lot of experience on it. There are also many social determinants of health, like people that live in more deprived socioeconomical areas are usually less referred to surgery or are less represented in the surgical cohort. So this is important also, and this is something that we have to consider. And yes, as we said, like the empowerment of the people, like people knowing that this is an option and what can you expect from it is a powerful tool to improve accessibility and to make the pathway faster, let's say, more effective, and don't get lost in the complexity of it.
So tell us about the actual pathway then. What is the process? Can you walk us through that, please?
So there is a common pathway where like the common line is the black line is for
the
Londoners.
Northern line.
Yeah, it's like the Northern line. It's my favorite line in London. I might be biased, but yes, this is the common thing that we are all going. Like every patient should go through the same stations. Let's say at the beginning, it all starts at the epilepsy clinic appointment, the first appointment, where we go through the history, the details of every seizure, and all the anti-seizure medication that patients have tried. After that, we will officially start the pathway, the pre-surgical pathway, after a discussion with the patient. And it always goes through, like, next station will be always an MRI, very advanced MRI. You may have had MRI in the past, but usually we do a very specific, like 3 Tesla high resolution MRI, and then it has to be read by a specialized neuroradiologist. So it's often the case that we find patients with no normal MRI or no lesion on the MRI, and then we look again into it and we find something. Up to 80% of the patients have some abnormality on the MRI if they're seen by expert, and this is a very important prognosis factor for surgery. So this is a very good thing to have something on the MRI, and the next things we do is an admission to a VT, to a video telemetry unit. Those are there are a few of them in the UK and in many countries. Like usually they are located in tertiary hospital, like big university hospital, where we admit patients for around 1 week and to record seizures, basically. We may need to reduce the anti-seizure medication to capture seizures, depending on the seizure frequency. We don't want big seizures. We want to record small seizures just to try to localize where all these seizures start from. So we'll do an EEG and a video recording of all the seizures. And in the middle, it's also like really important to have a neuropsychological and a psychiatry an assessment with a psychiatrist. The neuropsychology will take around 1 to 3 hours, and she or he will do a lot of tests to check for, especially for memory and language, and try to understand like what would be the impact of surgery in your specific situation, in your life, in your job.
And it can depend upon the type of surgery that you have, right? And also how much tissue is affected by the surgery, and that can affect what the surgeons actually choose to do, right?
Exactly. At the beginning of the journey, neuropsychology will assess everything, language, memory, your current state, and then she or he will give us some insight about the impact of a potential surgery, depending on of course, the type on that specific person. We will also do a functional MRI that is important to localize where your language is, in which side of your brain. If it's left or right, it's usually left. But this will be important to preserve that function then later. So with all that information, we will arrive to the MDT station, that it's the equivalent to King's Cross.
Again, everyone, please look at this. When Ricardo texted it to me, I was like, dude, this is so cool. Like,
so this is a big station, the MDT station. This is our the main hub of our pathway, because this is a meeting. MDT means multidisciplinary team meeting. In all the countries, they may call it different, like session or meeting, but at the end it's the same. It's where we meet, all the team meet together at the same time. All the team means the neurologist, the neurophysiologist, the surgeons, the neuropsychologist, the psychiatrist, the radiologist, nuclear medicine team, and the consultant or the clinician that is responsible for that specific patient. So we all meet there and we discuss, we review all these tests together, the MRI, the EEG, the neuropsychology, and our job is to try to arrive or agree on one hypothesis of where this epilepsy comes from. This is something important because usually the best candidate for epilepsy surgery are people that we thought that they have focal epilepsy. You know that there are two big types of epilepsy: generalized epilepsy and focal epilepsy. In general, generalized epilepsy are not very good candidate for surgery, although we have to study them because sometimes we think it's generalized and then it ends up to be focal, but spreading very quickly. So the main objective is to try to localize one area of your brain where the seizure starts. And this is what we call the epileptogenic zones. It's the area that we potentially have to remove or treat or lesion to leave the patient seizure free, to reduce the burden of seizures. This is one of our main tasks, but the second one is to protect other important critical areas of the brain areas that are responsible for language, for memory. So we always have to think about the two things, the epileptogenic zone and all the important areas of your brain that are very close to it. So we have to protect one and try to remove the other one.
And also areas responsible for mood as well, right? It's not just about cognition and intellect, for instance, but also about the mood of the person afterwards. So I think you have to look at, is that not true that with the neuropsychologist, they'll look at the person's mental health history as well, and then what could be the potential impact of the surgery short and long term?
And this is one of the main tasks of the psychiatrists, although the psychologists also take a look at it. The psychiatrists will tell us the risk, will assess first the previous history of psychiatric disease, mood disorders, mood problems, or other kind of things. It's usually anxiety or depression, the most common part of the epilepsy. In fact, we used to call it comorbidities, but now we know that it's a morbidity part of the epilepsy spectrum. And yes, we take that into account. Also potentially vision problems that may come if we remove one part of the brain. But yes, these are the things that we take into account. And then with all that information, we make one out of 4 decisions. So you can, from the MDT station, you can take 4 possible routes. Those are the different colors in the map. So one of the situation is when, after we review all the tests, we feel that we don't have enough information to make a decision right now, and this is when we go to the blue line, let's say, with the Piccadilly line here in London. That is when we need more information to make a decision, and the outcome of the MDT will be for further investigation. That means sometimes we need to repeat some of the tests, do another MRI. Sometimes we do a PET scan, which is basically a nuclear medicine test where we inject a sugar, radioactive sugar, to see where it goes into the brain and to see how active is every area of the brain. Usually where we see the seizure onset, the epileptogenic zone, let's say, is usually hypoactive. So they, in a normal intraictal state, they eat less sugar, that area of the brain.
They consume yet less. Yeah, no, that would make sense. They need the energy for the seizure, right?
They need energy to discharge during the seizure. We can also do a SPECT. SPECT is a bit more advanced test where we will admit the patient to a video telemetry again for an injection of again a nuclear radioactive tracer that we inject during the seizure, and it will stay there in the brain, and then we do a scan in the next few hours, and we follow the blood flow because we know that during seizure you need more energy, you need more blood in that area of the brain. So we use that information to localize the seizure onset, where the seizure starts in your brain. And then with all this new information, you look back to the MDT. So you will have another MDT discussion after that. And we will see if with that new information, you can have another outcome. This is important because many people get lost in that loop. So we sometimes ask for new information and it takes a lot of time to get the new test. Sometimes people get better in the meantime. So yes, this is important to know. Then the other very good scenario is when we say, okay, we have enough information, everything is concordant, this person can go straight to surgery. And this is a very good outcome also for the patient. And then you will have a meeting with the surgeons and with your consultant or attending physicians, and you will discuss specifically which type of surgery we think is best for you and the potential odds for seizure freedoms. that has to be individualized.
Versus the potential impact of having the surgery as well. So the impact can be seizure freedom, but it can also sometimes, not always, but sometimes have some negative or detrimental impacts on other things.
We have to always make sure that the risk benefits of doing surgery is balanced towards the benefits and if of course it's a shared decision. So we discuss with the patient what are they willing to risk, what are the risks that they can accept, and at the end this is a shared decision. And patient has a lot of power and opinion on that.
But it needs to be an educated decision. I think sometimes people can be very scared of surgery, like, oh, you're going to chop my brain up. Whereas it's an extremely safe thing to do. We wouldn't do it so often. And also, we need to be looking, I think sometimes we, patients, people with epilepsy, and even sometimes carers don't actually realise the risks of having seizures.
Exactly.
And things like not solely injury, but physical injury, but psychiatric injury, and also SUDEP. And of course, the detriment to your brain every time you seize. Like, people don't really talk about it, but seizures do cause injury to the brain.
And SUDEP is highly prevalent in this population of drug-resistant patient with drug-resistant epilepsy. The SUDEP risk is up to 10 times higher than the rest of the population with epilepsy. So this is a serious topic here in this group of patients. Another potential option for the MDT outcome for the MDT will be for intracranial EEG. That means that we need more like invasive investigation to understand where the seizure comes from. That means that we will place very thin electrodes into your brain for a very short time, usually it's 1 or 2 weeks, to record seizure directly from inside the brain. So we can localize specifically where the seizure comes from. It's a very advanced technique, it's a powerful tool, and it helps us also to understand the network, the seizure network more precisely, and to protect some other important areas that are close to that network. Sometimes we do an intracranial because we don't have any lesion on the MRI, and we need to be more precise about where is this epileptogenic zone. And sometimes we do have a lesion, so we know potentially where the seizure comes from because the EEG comes from there and everything is concordant, but there is something important very close to that area. For instance, language. We know that language is very close to that area, so we have to make sure that we protect it during the surgery. So sometimes we need to do this next step, that is intracranial EEG or SEEG. This is another name. In the past, we used to do a lot of subdural grids, but usually most of the centers, we're not doing it anymore. We do intracranial electrodes, depth electrodes, as we mentioned.
Worth saying, I think, with intracranial EEGs, of course, there can be some pain from going into the skull, but the brain feels no pain, right?
No, exactly.
Yeah, when you plonk something in there, even if it was a massive thing, which it obviously won't be, tiny, tiny little electrodes you put in there is no pain from that itself.
No, the main risk of doing an intracranial is, of course, it's usually around 2 to 3% in general of complications. The most common one could be infection, of course, because we are inserting, but we take a lot of precautions. And the second, that is around 2 to 3% of the cases, and less than 1%, around 1%, we can have bleeding. That's why we map all the blood vessels before doing an intracranial, and we have 3D images of your brain, and we try to avoid blood vessels. But bleeding could be, symptomatic bleeding could happen up to 1% of the cases, and any serious things like stroke or anything is rare, like less than 1% of the patient can have something like that. So it's a safe procedure. And after the intracranial, we have a lot of information, and we do a new kind of MDT, and we decide usually around 60 to 70% of the people we can recommend surgery afterwards.
So what are often the type of results that people see after surgery? And I know, like, what a patient considers a good result can be very different depending upon what they've been led to believe is a good result afterwards. And how do you manage that?
I think it's really important, especially to have a personalized discussion with your consultant, with your doctor, because every patient is different. In general, we have two main types of surgery, like resective surgery that moves removing one part of the brain, or laser.
Mm-hmm.
Laser right now has very specific indications, so we will talk about resective surgery. The best case scenario will be like a temporal lobe epilepsy with something that is called hippocampal sclerosis, like scarring in a structure, very small structure that is called hippocampus, that is very important for memory, but it's also deep down the brain. Is also really one of the most common causes of epilepsy because it's always very active. And in those cases, with everything, all the tests are concordant, and we have epilepsy coming from the hippocampus, it could be up to 70% of seizure freedom in the first year after surgery. So this is the best case scenario in epilepsy surgery. And when we follow up those patients during up to 10 years, still more than 50% are seizure free. We have a certain percentage to be seizure-free, and we give another percentage of significantly improved seizure control, but not being seizure-freedom. And all those numbers, you have to discuss it with your clinician. And beyond seizure control, many people after report improvement in mood, improving cognition, and as we mentioned again, the SUDEP risk is significantly reduced. In terms of anti-seizure medication, that is a common question. The majority of the people keep anti-seizure medication after surgery, but we might be able to lower the dose to significantly reduce the amount of anti-seizure medication. And there is a percentage of people, like around 30%, if they are truly seizure-free after a couple of years, we can even stop anti-seizure medication.
See how it goes. I guess you'll always be monitoring it and do it very, very slowly as well, right?
Exactly.
I know two other people, as well as in addition to myself, who've had temporal lobectomy, and they're both, and I are still on the medication, but it's still, we believe, totally worth doing because it's improved quality of life so significantly. My neurologist said way back, I don't know if I've told you this, but he said to me, he knew me very well and said, your life expectancy isn't that great. Would you consider surgery? And I so appreciated that. And I think more clinicians need to say that, because I wonder if more people like myself would actually say, oh my God, I'm going to take this a bit more seriously now. Yes, I will consider surgery.
Yeah, this is important. And it's also important to know that there's a pathway for people. There's a route for people that are not candidate for surgery. We now have neuromodulation. We have new drugs coming on. We have clinical trials available in all major countries in Europe, in the US, in Australia, in many other countries, in Latin America. You have to ask your clinician about what's available in your country. And there are many options, even for patients that are not suitable for surgery right now.
Yeah, I would encourage any patients or families listening, please take this episode to your clinician, whether it's your GP/physician, whether it's your neurologist, because not all neurologists even know about this stuff either, and to say, actually, what about me for this? Or for my loved one? Would this be a good idea? And if you're a clinician and you're like, I don't know about any of this, and it sounds a bit scary almost, but I even consider this for my patient, please just read more into it. It's becoming much, much more common because it's so safe to have these surgeries now, and increases life expectancy in so many cases and increases quality of life in so many cases.
Exactly. And the big message is you're not alone. We're a team. This is a complex pathway for everyone. There are many associations, like we have here Brain Body in the UK, the Epilepsy Society, but there are many associations of patients that also bring support to people, give support to people that are going through this epilepsy surgery management pathway. And ask, and don't be afraid to ask about surgery and to discuss with your doctors and your family about it.
I've experienced much more pain in hand surgery than I did in brain surgery. No joke. Or with a migraine. Was way more painful than brain surgery. But we're not saying it's not suitable for everybody, but there are many, many choices. If you look again at your tube map, the pathway, which will be on the website as well, so check it out, that there are, as you say, other options. It's not just about scooping out a dodgy bit of your brain. There are other things too that can be used in many cases to improve quality of life for people with an epilepsy.
Thank you for watching. Don't forget to like, subscribe and share this episode with colleagues, friends or family, whether you're a clinician, a researcher, caregiver or somebody living with an epilepsy. Check out Ricardo's tube map of the epilepsy surgery pathway on our website, link below. It is a clear and empowering visual for understanding and discussing options in the epilepsies. Explore more Epilepsy Sparks Insights episodes for hopeful, evidence-based conversations from leaders in the field. And let us know your thoughts or experiences in the comments. We do love hearing from professionals, caregivers, and people with lived experience alike.